So let's welcome Jeffrey Lazarus, Professor of Global Health at CUNY Graduate School of Public Health in New York, and the Head of Public Health Liver and Group IS Global, and Associate Professor of University of Barcelona, and Chair of Healthy Livers, Healthy Lives Initiative. He's going to talk to us about the results of multi-country viral hepatitis community screening, vaccination, and care program. Thank you, Professor, for being here with us.
Thank you for the introduction. Thank you for the invitation. Yeah, so some of the countries that have been doing best, traditionally have been Australia, the country of Georgia in the Caucasus, Iceland to some extent, also Spain. And what we really learned about them, and parts of Scotland I would add as well, is that they have a strategy, and a strategy that's been approved by the government. In the case of Australia for hepatitis C, they were able to negotiate good prices for DAAs to treat and cure, obtain a sustained virologic response for hepatitis C. Also in Iceland, I realize it's a small country, but they had strong government support. So I think having government support is key. We have this bottom-up approach from all of us with our projects and at our hospitals and clinics, but when we get the top-down approach from governments, we move a lot faster. So I think a strategy and an action plan is key. I know there's one in Andalusia that I contributed to. There's one in Catalonia. There's one across Spain, and that's made one of the big differences.
Okay. I was wondering, in terms of the intercultural mediators in the study, how were they selected and trained, and did they have a huge impact in the screenings? Thank you.
They had a huge impact. Without them, this would have been completely impossible, really. They opened the door to the community. They're with us giving talks at the beginning of each session, introducing us to them and really helping the community understand what we want to do from a community that sometimes may fear the authorities, including the health system. They were trained by us, but also by a group we collaborate. It's called Salud Entre Culturas in Madrid, as well as by a group of colleagues who work with one of the CAPs, the Centros de Atención Primaria, in Barcelona. So they're given that kind of training more around viral hepatitis because they're already experienced, usually as mediators. A couple of them came from my students in the master's course at IS Global, and some came through the organizations, like the organization of Ghanaian people or Senegalese people in Spain or in Catalonia who we engaged with, and they recommended people. And then we actually paid them a small honorarium for their work, and I think it's important to remunerate those who are going to do the work with us in the field.
So my question is, in a context where viral hepatitis remains a silent epidemic like in developing countries, how can we better leverage public health data and digital innovation to drive more effective policies, especially in countries with fragmented health systems?
Yeah, well, it is a big challenge particularly in low-income countries where they have so many competing priorities. So I think monitoring and evaluation has been really important, and that's why WHO plays an important role. WHO, in terms of budget and staff, is relatively small. I worked there 11 years. We don't do a lot of implementation, but in terms of collecting data, this helps put the pressure on governments to collect the data in the first place. And then there are league tables, and it shows how well they're doing. So why are they doing better or worse than their neighbors? So I think collaborating, let's say with the particular WHO regional office is important. And then I think it's linking up. You asked about digital tools. It's linking up to ongoing services. So if there are better diabetes services or HIV services, it's linking up with those services. So we have a paper out last year in the Lancet on integrating care, where we looked at bringing diabetes and hypertension services into HIV services in Tanzania and Uganda. It was a cluster randomized controlled trial, but I think that's one of the ways forward. As HIV services are doing well and are well funded, it's what can we do for in those services, not everyone had HIV, or for those populations. The other trial I mentioned was testing metformin among people living with HIV and prediabetes to to see if it will stop progression. So where there's better funded services, it's looking at how we can collaborate. And I think digital tools, I mean, it is the future, but in some ways we've seen that future in low income countries get ahead of us in high income countries, because where doctors are far away, we've seen radio services 20, 30 years ago provide HIV information where there were no health services to reach those populations. So I think we need to get better, much better at harnessing those services, as well as self-tests. So now we have a hepatitis C pre-qualified by WHO. It's made by OraSure. So we have a hepatitis C swab where people can test themselves. So we need to have services that will support the population, but also tools that they can use themselves.
Thank you, Professor Jeffrey. Very quickly, you had expressed before the challenges in the continuation of care, and we're talking about particular population, undocumented, very mobile. And we heard even before in another study here in Andalusia, the challenges of keeping the people in the program. Is there any good practice you want to share with us, how we can keep the people in the system if to diagnose them, for example, in Lampedusa, and the people keep moving? Thank you.
Well, it also depends where they move, because, as you know, in Spain, you have a decentralized healthcare system. So even for Spanish people, changing autonomous community can be quite challenging. One thing that was exceptional, I think, in Catalonia was that for those who were undocumented, we were able to provide them with a health card for 1 year. So together with the Red Cross and the authorities at the Generalitat, they allowed us to provide the card that would give them all healthcare. So actually our program became a beacon for people who wanted to know if they had hepatitis B, but also were able to get into the system. No judging, no questions about why and how they got to Barcelona or the greater Barcelona area. But we focused on their health issues. At the same time, Madrid was making it very difficult for migrants, undocumented in particular, to get their HIV treatment. So I think if we want to focus on people's health, we need to make them feel comfortable with those services. But if they're moving between EU countries, it's very challenging, and often, we can explain, but we've had people we've reached with really nothing, just a knapsack. So I don't expect them to know if they had their second dose of the hepatitis B vaccine or not. So that is a challenge. And I guess my last comment is, working with the community and stressing the importance of the community supporting them. So when we're not there, the community is also talking about health issues. And it's been remarkable to see, again, reverends, pastors, imams talking about the importance of health to their community and working together as a community.
Considering that many viral hepatitis cases remain diagnosed, what do you see as the key steps to integrate screening and treatment into primary care without overburdening healthcare professionals?
Yeah, it's one of the big questions, because primary care, has enough to do. So of course there's risk screening, so there can be questions about where people are from or their lifestyle habits, but we know that can also be very stigmatizing. I think alert systems for viral hepatitis can work in primary care, posters and information materials. But, I think the studies show that in the Barcelona area, you would test 1,000 people before you found one positive. So we need to get much better at engaging with the communities that we know are higher risk. I think primary care should have the offer and engage on biohepatitis testing, but I think the answer lies in addiction centers, community centers, and really outside the formal health system. And we've seen remarkable things. We worked with 14 addiction centers across the Balearic Islands, so in Mallorca, Menorca, Ibiza, even Formentera, and we were able to test thousands of people and find a very high prevalence, 10% by working with the addiction centers. It takes more effort, but we need to go to where the virus is and not hope that those people show up and actually get tested in primary care.
Hello, and thank you for your presentation. My name is Louis. I'm a pharmacist from France, and I was wondering, since my country is in the middle of the immigration in Europe between Spain, Italy, and Great Britain, I was wondering if you knew what my country was doing in the hepatitis world to fight against all of this.
Yeah, I mean, I'm not an expert on what's going on in France, but I know that your harm reduction services are starting to engage on viral hepatitis. I know that community groups are very active, but I'm not so sure with regards to migrants what's happening. I know Italy has taken a lot of action at the borders where migrants are arriving from sub-Saharan Africa with testing programs. I'm not sure if that's the case in France as well.
Okay. Do you wish France was more proactive with you working
When we
together
look,
in Italy?
yeah, I mean, when we look at sort of global data or EU data, France never really sticks out to me as a country that's doing particularly good. Not that they're doing particularly bad, but I haven't seen France as an example. Things may have changed in the past few years, but I guess before the COVID pandemic, so already 5 years ago, France was never really an example country. They weren't one of the first to have a national plan to address viral hepatitis. They do have one of the great virologists in the world, and they've done amazing work on the development and use and testing of DAAs. With people like, Dr. Jean-Michel Pavlovsky in Paris, but I haven't seen France really setting an example. Whereas, for example, in Spain, they declared universal access to DAAs for hepatitis C very early on and treated over 150,000 very quickly. So for many years, Spain was the country that had most treated and cured people living with hepatitis C.
Thanks a lot for your voice.
Well, thank you very much for having me, and have a good rest of your day.